Let's review another interesting case. The patient is a 54-year-old man who presented with a 2 cm mass on the elbow. On low-power examination of the resected specimen, the neoplasm is located within the dermis, with an intact overlying epidermis. No necrosis is identified. On high-power examination, the tumor is composed of sheets of neoplastic cells with admixed lymphocytes. A mitotic figure is present in this field, highlighted by the red circle. The tumor cells show striking nuclear pleomorphism. Compared with background lymphocytes, the nuclei are at least 3 times larger. There is marked variation in nuclear size and shape, along with prominent cherry red nucleoli. The cytoplasm is abundant and ranges from granular to glassy. Another high-power field further highlights the characteristic glassy cytoplasm and pronounced nuclear atypia. Immunohistochemical studies demonstrate diffuse positivity for CD34 and focal positivity for pancytokeratin. The tumor cells are negative for S100, SOX10, SMA, desmin, CD31, and ERG. The second patient is a 52-year-old man with a mass in the arm, similar in age and anatomic location to the first case. On low-power examination, the lesion is well circumscribed, with focal infiltration into the adjacent adipose tissue. In this picture, we can see that the tumor cells form intersecting fascicles. This lesion is more spindle and more cellular than our first case. Nuclear atypia is obvious even at this magnification. At higher magnification, the tumor is a hypercellular spindle cell neoplasm with scattered admixed lymphocytes. The nuclear pleomorphism is again striking, with significant variation in nuclear size and shape. Frequent nuclear inclusions are present. Notably, no mitotic figures are identified. Given the degree of nuclear atypia, increased mitotic activity might be expected. However, this discrepancy between marked cytologic atypia and low mitotic activity is a characteristic feature of this tumor. Immunohistochemistry shows diffuse CD34 positivity in the tumor cells. The diagnosis for both cases is superficial CD34 positive fibroblastic tumor. This is a relatively recently described entity and is included in the latest WHO classification. These tumors arise in superficial soft tissues, involving either the dermis or subcutaneous tissue. The most common anatomic location is the extremities, although cases have also been reported in the buttock, trunk, and perianal region. While more common in young adults, the reported age range is broad, from 14 to 85 years. Tumor size ranges from 1.5 to 10 centimeters. Superficial CD34 positive fibroblastic tumor is considered a low-grade neoplasm, with rare local recurrences and only one reported case of lymph node metastasis. Histologically, the tumor is typically well circumscribed at low power, with focal infiltrative growth evident at higher magnification, consistent with its slow-growing, low-grade behavior. The tumor is composed of spindle cells with abundant granular to glassy eosinophilic cytoplasm and striking nuclear pleomorphism. A defining feature is the very low mitotic rate. Many cases show no mitotic activity at all, creating a characteristic discrepancy between cytologic atypia and proliferation. Immunohistochemically, the tumor shows diffuse CD34 positivity. Cadm3 is positive in the majority of cases, although this antibody is not widely available. Focal keratin positivity is seen in approximately 70% of tumors. A subset of cases demonstrates PRDM10 gene rearrangement. No other recurrent genetic alterations have been identified. In summary, when encountering a superficial soft tissue neoplasm with marked nuclear atypia, abundant eosinophilic cytoplasm, very low mitotic activity, a mixed inflammatory background, and diffuse CD34 positivity, superficial CD34 positive fibroblastic tumor should be strongly considered. This is a low-grade tumor with an excellent prognosis and rare recurrence or metastasis.